still stand the chance of having tuberculosis. So the BCG doesn't give you a lifelong immunity that once you get it, you can never have TB. We've had people that had BCG as babies and still develop tuberculosis along the way.
Okay, so that would make one wonder, why don't we vaccinate the adults instead of the children?
Recently, we've had some adults that come in, maybe they're going for a postgraduate study abroad, and the universities over there are asking for BCG vaccination, which we always ask for them to do a mantle test first before we inject them, for those that don't know.
Okay, that's the test that shows whether the bacteria are there.
Yes, or not, whether the person is positive or negative. But the truth about it is, we wouldn't say because tuberculosis is rampant, oh, don't get BCG. Like, don't take anti-malaria, because even if you do, you will still come down with malaria.
Okay, so at least it still confers a bit of protection.
Yes, it still confers a bit of protection. So, in my words, I would say it's very, very important.
Okay, now, I learned that a third of the world's population has latent TB. Mm-hmm. They are carrying it about. How does that change the story of TB? What's the implication of that?
A third of the world is carrying it because latent TB is just that you're carrying the microbacterium or you've been exposed to it. But because your immunity is suppressing that bacteria, you've not come up with the TB symptoms. Everybody can carry it, doesn't mean because of the environment that we live in, because of the exposure. So having latent TB doesn't necessarily mean that you have tuberculosis or that you would come down with tuberculosis. The major thing we should fight is those that already have the active TB. Because as a latent carrier, you can't infect others unless the immunity you have has failed. That's when the tuberculosis would now be reactivated.
Okay, so is it like malaria that they say, oh, everybody has malaria in their system, but when you break down, or if your immunity goes down, then the thing starts to rise up. At that point, that person can begin to infect others.
Yes.
That means that immunity is a big deal.
It's key.
Okay, so maybe you start to treat somebody with TB.
Okay.
How long does it take for the person to be cured?
Okay, we have different groups, regimen. We have regimen 1, regimen 2. Regimen 1 is for the pulmonary TB, which is 6 months. We have 2 months and the 4 months medications. Then regimen 2 is 8 months. Multi-drug resistance can last up to 20 months. So the least you can get or you can be treated is 6 months.
6 months.
There's nothing less than that.
Is that every day of the 6 months?
Yes, it's every day. There's no miss.
It can be a bit difficult to comply with such a strict regimen. A tablet, or I don't know how many tablets, every day for 6 months. I imagine that some people would fail sometimes.
A lot of people fail.
So how do you handle that?
Okay. So what we do, we have a lot of referral centers in Lagos. So the patient comes, where do you live? Oh, I live in Surulere. We'll get a referral center close to where, unless the patient opts out. Oh, please, I don't want to be seen around Surulere. I still want to continue my treatment in Ikeja. And we also do follow-ups.
Okay.
Not that we just give them medications and say, oh, okay, bye. So we have a record with all their numbers. So we keep calling. And before we start you on medications, you have to come in with a family member. We get the family member's number and also get the patient's number. So if you don't show up, we're calling your family member. So we keep calling. We even do home visits too.
That sounds wonderful. Does this happen?
It does.
Everywhere. It really does happen.
I can only speak for Lasut where I work. But I'm so sure that other centers do it, because that's what the DOTS, directly observed treatment short course, is all about, where you have a close relationship with your client to break this burden of disease.
Okay, let me just move a bit to the practitioners now.
Okay.
You're treating all these TB patients. What do doctors do to protect themselves?
we eat well. So if you're in chest clinic in Lassus, we always advise everyone, all the doctors, all the health workers, to feed well. So if you feed well, you have a good immunity.
Gloves, gloves,
basically,
masks.
We don't do that because you're stigmatizing the patient. Once you wear your gloves, you wear a mask, you're shielding that patient away from you, and we don't want any defaulter. We don't want to miss a case. So the treatment you give them on the day they come in matters a lot. If you wear all your gloves and you don't even want the patient to come close to you, how do you examine them? Because we listen to their chest as well.
But I thought we should have gone beyond the point where, you know, a patient is feeling bad about the doctor wearing gloves and a mask. You know the problem, the condition you came in with, and the primary thing is, let me just be free of this. And the person is wearing the mask within the confines of the hospital anyway.
Yeah. So what we did was to tell the patients themselves to wear masks.
Okay.
And all the consulting rooms are well ventilated. So you have the consultant's chair and the table far away from the patient. So in that way, you're still in the same room, but the room has 2 windows where air flows in and, you know, flows out. And we keep advising the patients too, in gentle tones, please, if you feel like coughing, go outside.
Okay.
But we are not allowed, for the Hippocratic oath. Who are you working for? The patient. In as much as you'd be scared, I've worked in the TB clinic for God knows when. I've not come down with TB. So, because I protect myself, I eat well, make sure the rooms are ventilated.
Okay, these are now preventive strategies,
Yes.
right?
Yes.
Ventilated rooms, proper food, and what else?
And we also use disinfectants on the floor. We sprinkle it. We make sure we clean. The cleaners, they're on their toes. They clean in the morning and they clean in the evening. And we also do health talks for our patients every Mondays. So we tell them, we're the ones treating you. You don't want to infect us, right? Because some of them, they are stubborn. They don't want to buy a mask. Oh, why would you make me pay for the mask? So we tell them, you know, we're the ones seeing you. You don't want us to die, do you? So please make sure you dress, put on your mask, come into the room. If you need to cough, go outside. And if you want to spit out, you're going to infect others too.
So spitting etiquette.
Yes, so we teach them to cough
into the elbow.
And we also into the elbow, and we also separate them when they come into the clinic. So we have the coughers and the non-coughers. So that those that are already, the coughers are the new patients, mainly the new patients. And while the non-coughers, they are already on their medication. So you don't.
Let's take a short break. We'll come back to that. We're taking a short break now. Please stay with us. We'll be right back.
Okay.